hyperparathyroidism, we can explore this implanted gland. Secondary hyperparathyroidism, the treatment is medical treatment. We have to give 1-alpha hydroxyl vitamin D3 or calcimimetic, which the medications or the drugs which turn off secretion of parathormone. It inhibits secretion of parathormone. While tertiary hyperparathyroidism, it needs surgical treatment in form of total parathyroidectomy, also with auto-transplant of one of the glands, as I said, in the sternomastoid or deltoid muscle or forearm muscle to facilitate its re-exploration if needed. Second disorders of parathyroid gland is hypoparathyroidism. In hypoparathyroidism, there is a decrease in the level of parathormone, which resulted in hypocalcemia. The etiology, the commonest causes are following: thyroid or parathyroid ovulation, idiopathic causes. After radioactive iodine therapy for Graves' disease, it causes destruction of parathyroid gland, or a state called pseudo-hypoparathyroidism, in which there is reduced sensitivity to parathormone. The pathology that results after hypoparathyroidism, there will be decrease in serum calcium, and this lead to an increased excitability of neuromuscular structures. Clinical picture: perioral paresthesia, cramps, and tetany. Chauvastic signs on tapping on facial nerve, there will be spasm of facial muscle. Trozius sign, after inflating blood pressure cuff to above systolic pressure, it will induce typical carbopedal spasm. The investigations that are required in hypoparathyroidism, serum calcium and parathormone both are decreased. ECG shows prolonged QT interval. Treatment by giving calcium and vitamin D. Let us now talk about adrenal glands, or what we call suprarenal glands. We have right and left suprarenal gland. Anatomy of suprarenal glands. Weight of a normal gland is about 4 grams. Yellowish in color, surrounded by penephric pad of fat. The right side is pyramidal in shape, while the left side is concentric in shape. Arterial supply of the adrenal gland from superior suprarenal by superior suprarenal from phrenic artery, or through middle suprarenal from aorta, or inferior suprarenal from renal artery. Venous drainage through left suprarenal vein and to the left renal vein, and through right suprarenal vein to inferior vena cava. About histology and physiology, it consists of 2 parts, cortex and medulla. The cortex is formed of 3 zones. First zone is zona granulosa, which secrete mineralocorticoids, and it is controlled by renin-angiotensin system. Second zone is zona fasciculata, which secrete glucocorticoids and controlled by ACTH, adrenocorticotropic hormone. Third zone is zona reticularis, which is responsible for secretion of androgen. The second part of adrenal gland is the adrenal medulla, which is responsible for secretion of catecholamines. Chromaffin cells, which is found in adrenal medulla, is part of Abbott's system. These are endocrine cells, which is part of Abbott's system. So this tumor, either solitary or part of main syndrome. Adrenal gland is essential for life, and it is the only gland which is fully developed at birth. Let us start with the adrenal neoplasm. And as we already divided it into adrenal medulla and adrenal cortex, let's start with tumors of adrenal cortex. Usually adenomas from different cortex zones, from different zones of the cortex. Adenocarcinoma are rare. And regarding the adenoma, it is either non-functioning adenoma or functioning adenoma, which may produce Cushing syndrome, Cohen's syndrome, adrenogenital syndrome, and feminizing syndrome, which is rare. And tumors of adrenal medulla, either tumors of the sympathetic neurons, which give us benign ganglioneuroma, which is benign neonatal tumor commonly arising from retroperitoneal lumbar sympathetic trunk, fine needle aspiration cytology, ultrasound followed by surgical excision is the management, or tumors of chromaffin cells, tumor of sympathetic neurons, second tumor is malignant neuroblastoma, or tumors of chromaffin cells, which give us what we call pheochromocytoma. About Cushing syndrome, which is from adenoma of the adrenal cortex, it refers to various clinical manifestations resulting from increased secretion of corticosteroid. When it is due to pituitary adenoma that secrete large amount of ACTH, it is called Cushing disease. It is called Cushing disease if it is due to pituitary adenoma that secrete large amount of ACTH. Also, there may be ectopic ACTH producing tumor result in Cushing syndrome. The commonly secreting tumor, ectopic ACTH producing tumor, is small cell lung cancer, foregut carcinoid, medullary carcinoma of thyroid, neuroendocrine pancreatic tumor. So we classify the Cushing syndrome into ACTH dependent and ACTH independent. ACTH dependent 70% from pituitary adenoma and the rest from ectopic ACTH producing tumor. And ACTH independent either due to adenoma, adrenal adenoma, or hyperplasia. Clinical features: increased corticosteroid result in elevated level of aldosterone and androgen, and all these elevated level of corticosteroid and aldosterone and androgen give us what we call Cushingoid faces, in which there is facial plethora, buffalo hump, and moon face. So the clinical features: there is central obesity, unusual site of obesity like supraclavicular spaces and posterior aspect of neck, secondary osteoporosis, which result in buffalo hump, and hypertension, hyperglycemia, hypokalemia, hirsutism, irregularities in menstruation, neurological symptoms which like the depression and mania, and gain in weight, and skin changes in form of abdominal striae, ecchymosis, acne, plethora due to thinning of subcutaneous tissue. All these, see the first letter of each sentence, which give us Cushing, word of Cushing. The required investigation we need to measure morning and midnight plasma cortisol level, which are usually increased. Also, we have to measure serum ACTH. If it is increased, it is from pituitary source or from ectopic ACTH. Also, we have to do CT scan chest CT scan and abdominal CT scan to assess adrenal and detect ectopic sites of production of ACTH. Treatment of Cushing syndrome. Medical treatment in form of ketoconazole and metyrabone. These medications can reduce steroid synthesis, thus symptoms can be controlled. They are also indicated if surgery is not possible. Also, we have surgical treatment in form of transsphenoid resection of ACTH producing pituitary tumor. And if there is functioning adenoma, adrenal adenoma, unilateral functioning adenoma, we may do adrenalectomy. In bilateral tumors, bilateral adrenalectomy, we do bilateral adrenalectomy. But most operatively, we have to give cortisone supplement. Another pathology that results from pituitary adenoma, functioning pituitary adrenal adenoma, functioning adrenal adenoma is Cone syndrome. There is adrenal cortical adenoma, which secrete aldosterone, result in hyperaldosteronism that cause sodium retention.